everybody. Recording live from somewhere. This is Zach Couples with episode number 106 of the Movement Debrief. And tonight, folks, it's going to be really good. I'm talking like real good. We're going to talk about pregnancy. How does pregnancy impact your movement capabilities? Stay tuned. We're going to talk about Pectus Excavatum. What is it? How could that potentially impact movement? Do you need to get surgery? Stay tuned. And last but not least, we're going to talk about Bruxism. What the bruck is going on with Bruxism? Are there some worthwhile treatments to improve your clenching at night? These are the questions that have been asked by the people. They'll be answered for the people by this people right here, fam recognized fam. Without further ado, let's debrief, shall we? The first question comes from Tristan. Here's what Tristan has to say. A mentee, an OG, all types of good stuff. He's double OG, in fact. Question: how does pregnancy change this stuff? By this stuff, he means movement. I have a patient who is compressed on all sides, very narrow infrasternal angle, but she is starting to show with her pregnancy and belly breathe more. Can that actually shift people to a wide infrasternal angle as the pregnancy progresses? And how do you adjust the breathing activities to avoid undesirable positions while with advancing pregnancy? Great question, great question. First off, what does pregnancy change? Let's talk about what it doesn't change first. The first thing is it does not change the structure of the axial skeleton. And that is what is related when we're talking about the infrasternal angle. There are certain things within the skeletal structure that may bias or predispose someone to having a more narrow infrasternal angle or a wide infrasternal angle. It is more anthropometric in nature. For example, we have different body types. There are some people who are very thin and narrow framed. There are some people who are wider framed. We are built for different things. Those body types are going to excel at different things. And that cannot be changed by anything, including pregnancy. In fact, I've seen a few different people throughout pregnancy. We had a woman at one of my first human matrices who was, I think she was 8 months pregnant. She was pretty close to having her child. And she's a very tiny woman. Measured her infrasternal angle was still narrow, even though she was showing to a high degree. What changes is not the position of the rib cage, but what changes is where the baby would be carried. For example, with someone who's a narrow infrasternal angle, you're getting more downward pressure based on the shape of the ventral cavity, as well as the positioning of the diaphragm. And that child may sit lower than someone who is a wider infrasternal angle, who has a more ascended pelvic floor that might actually push the viscera up higher within the ventral cavity, and that child may actually sit a little bit higher in the woman's abdominal region. So that's really the only difference between those cases. It's not that she's going to get wider, but what may happen is as she progresses through her pregnancy, you may see a continual reduction of movement options within the ventral cavity, and that's despite having the increased laxity that occurs due to the hormonal things with pregnancy. The reason why that is because as we move, like in all our joints, we're moving synovial fluid from one direction to the other when we're, say, flexing or extending the elbow. That same principle applies in the thorax and the abdominal region. In the thorax, instead of moving fluid, you at least hope, you're moving air. And so if I go to touch my toes, I have to reduce airflow in the front of the chest and push more air into the upper back. If I'm going to touch my toes, I need to be able to push in the abdominal region, I need to be able to push the viscera posteriorly. So I get increased compressive forces on the front, which will allow for increased expansive or eccentric forces on the back. Well, what happens if you got a bambino sitting in there? Well, then you've got some problems because I now have a structural abnormality, i.e. pregnancy, or increased stuff in the abdominal pelvic region that I might not necessarily be able to push as well as I did before pregnancy. Now you might actually have more movement limitations within the axial skeleton because you can't slosh the visceral contents around as effectively. The same thing happens in people who are obese. If they have an inability to touch their toes or they lose the capability of squat or movement options, it could be because there is a structural impediment that is limiting those people from creating movement. I have a good example of that. I over the summer, put on some pounds. I was in gains mode, and I went too far. Even though a loved one of mine did not tell me that I went too far, I thought that she kind of liked me a little bit thicker. But I got too thick. And as I increased my weight, I lost my ability to squat, because I can squat all the way down pretty easily otherwise. But I couldn't do that once I popped on 20 pounds. I go to Costa Rica, my boy Ben House, who I'll link in the show notes, which will be on ZachCouples.com at some point, either today or tomorrow. He measures me, body fat-wise, and I was measured last time I was in Costa Rica. He says, Zach, you're up to like 25% body fat. I'm like, whoa, your boy got fat. What the heck happened? And so I had to drop the weight subsequently so I could move again. And sure enough, as soon as I lost the weight, I was able to regain my squat, no problems. Well, the same thing can happen with pregnancy. If I have increased weight within the viscera, i.e. a baby, you might not be able to move stuff as effectively, and that could limit your movement capabilities. So this is unfortunately par for the course as you're going on through pregnancy. So just be mindful of that you still want to try to push and improve movement options, but you want to do so in a manner, or realize that you might have a structural limitation that could impact how well you do. But that doesn't mean you should stop. How do I adjust breathing activities to avoid undesirable positions when advancing pregnancy? There's a little bit of controversy surrounding whether or not what Tristan's talking about is the supine position might not be desirable for some people, because when you're supine, that might put pressure on the aorta because you have this increased abdominal mass from the child, and might limit blood flow, could lead to a lot of negative implications, obviously. So the question is it safe to be in that position? I found that the research is kind of hit or miss in terms of if there are negative things that go on. I would say you modify in the sense that you would monitor any symptoms that might creep up within various positions. I've put a woman who was fairly late in her pregnancy in the supine position. We didn't seem to have any negative complications, especially if you're doing it for just an exercise. Probably a different story if you're having them sleep in that position for 8 hours. But if you're spending a minute in that position, probably not going to kill the baby, and it's probably not going to kill the mother. So that would be one thing to consider. An interesting tidbit. I took a myofunctional therapy course over the month of December, and I'll link these people in the show notes because I really like what they're doing. And eventually I will be doing a course review on that because it was really good. One of the better courses I've taken in a while. And they mentioned a study where they gave women in late trimester, breathing-wise, they gave women who were in the last trimester a CPAP. And here's the cool thing. Just by implementing a CPAP, that significantly reduced the number of babies that were born prematurely. Isn't that wild? The thought process is, as a woman increases their abdominal mass, that could potentially restrict their breathing capabilities. So you give them something short-term to improve their breathing capabilities, and then that might not create a stressful event that leads to the baby being born prematurely, because that could potentially be one reason as to why premature births occur. So you may consider, with someone who is pregnant, just making sure that their airway is checked out. You could have them collaborate with perhaps an ENT or a dentist or something like that. Make sure you ask that their sleep is going okay, that they're getting good sleep, they're not waking up frequently. That would be another thing to potentially consider for your client who is pregnant. To summarize, This is a great question, Tristan. Pregnancy will not change structure, but it could potentially impact movement options just because you can't move the viscera around as effectively. Position-wise, don't utilize positions that would increase any symptoms they may have. If you're going to keep them in supine position for short periods of time, it's probably okay. Last but not least, make sure that you are checking other airway things with people who are pregnant, especially as the trimesters go on. And if you do those things, you and your pregnant fam ought to be in business. Tristan, great question. The next question comes from Jamie. Here's what Jamie has to say. I have a question for a debrief. Talk to me about Pectus Excavatum. Breathing is obviously an issue for these people. What are some of your favorite exercises to get these patients breathing better? Awesome question, Jamie. Pectus excavatum, what is that? Basically, you have a sunken chest. There is anatomical changes within the sternum that push the sternum either downward and slightly posteriorly. In some people, that can restrict movement in the thorax. That could potentially impact cardiac function in terms of the worst case scenario because you're getting compression on the heart. That can reduce stroke volume and lead to a wide variety of problems. But this is not in all cases of those who have Pectus excavatum. Last but not least, another thing that they talk about in the literature in regards to Pectus excavatum is that there could be some negative things, body image-wise, that occur with someone who has a pectus. The question is, what kind of things would that influence movement-wise? What are our options? If I have a Pectus excavatum, that could potentially impact how well I can get air into the upper thorax. In particular, if I am locked down because of a structural issue within my sternum, I might not be able to pump handle as effectively as I could had I not had that restriction. For those who don't know what the pump handle is, that's when the sternum moves anteriorly and superiorly upon inhalation. The Pectus excavatum is essentially a down pump handle that is structural in this case. Limitations that might happen with that could be limitations in shoulder internal rotation, could also limit horizontal adduction, as well as shoulder extension. Those three tests are some ways that you can say, yes, this person has a down pump handle. If we're talking about potential symptoms, at the worst case scenario, you could have some cardiac stuff going on. What you gonna do about it? I'm glad you asked, Jamie. First off, the first thing I want to make certain is just because you have a pectus does not mean that you are SOL, you're screwed. Doesn't mean that you can never improve your movement capabilities. The human body is incredibly good at compensating for a wide variety of things and structural abnormalities. For example, there's a lot of individuals out there who can have ACL tears and not necessarily need a surgery and still be able to return to their prior level of function. The human body is wonderful at adapting to these types of things. You can still likely get air into the front of the chest because we don't necessarily know to what extent having a Pectus excavatum is a rate-limiting step for putting air into the front of the chest. I've worked with a few people who've had a pectus where we've gotten substantial, if not full range of motion, despite having this structural abnormality. Your first line of defense would be to do all that you can movement-wise to improve pump handle mechanics. I'll link a couple of my favorite activities in the show notes, but generally if you want to improve pump handle, reaching from above 60 degrees to all the way up overhead can lead to an improvement in pump handle mechanics. I'll discuss that a little bit more in a future debrief, but just remember, think forward reaching or arms completely overhead. Those would be great for improving pump handle mechanics. Now, that being said, if you have a situation where you find that your person you're working with or yourself, if you have a pectus, are having some cardiac signs, you're having dyspnea, shortness of breath, you are having an arrhythmia or other cardiac things, you may consider getting evaluated by a medical practitioner because there could potentially be some severe negative consequences to your heart if you have a pectus. If there's a substantial amount of compression on the heart, Stroke volume can be reduced. That could potentially kill people over time. Not like if you have one right now, you're going to die. But get checked out. In fact, there's actually some good research. This study is called Outcome of Surgical Repair of Pectus Excavatum in Adults. So this is cool. Where they basically, for the surgical procedure, put a bar in front of or behind the sternum to push it away to increase space within the thorax. And they actually had some pretty good results. Aside from some favorable cosmetic changes, which from a psychological perspective is important, they had some substantial improvements in ratings of dyspnea, shortness of breath, for this population. Think about the performance implications of that. So the surgery, if you are a surgical candidate for your pectus, is actually pretty good and it's pretty effective. It might be worth considering looking into. But if you don't have those cardiac symptoms and you're just looking to improve your movement capabilities, I would make sure you exhaust all conservative measures first and foremost. And those would be the big things I would say about Pectus excavatum. So to summarize your question, Jamie, Pectus excavatum, sunken chest, structural abnormality, could potentially have some cardiac issues, but not always in all cases. It depends on the degree and the severity in the person. You would have potentially a reduction of anterior chest wall expansion or pump handle mechanics. To improve pump handle mechanics, you want to reach above 60 degrees all the way to overhead. But I usually start most people in that 60 to 120 range, eventually progressing to overhead, assuming that you can maintain lower thorax position. If you've done that, you've truly exhausted this, you've mastered the basics, you have cardiac symptoms, you're not getting the movement improvements you want, especially the cardiac symptoms, then you may consider the surgical procedure, but you have to get evaluated by a qualified physician to make sure that you are a candidate for that. But the surgery does have some pretty good results. Awesome question, Jamie. Now, if you're wondering, well, Zach, maybe I have a pectus, and you talked about reaching in these positions, but I don't know really how to coach myself into these positions or what kind of cues and things I need to focus on when I'm talking about these reaches. Or perhaps you are just like, man, I would love to be able to go overhead and I'm limited, and maybe that's because I can't move air effectively into the front of my chest. Or you're wondering, well, I'm a trainer and I don't know a lot of the basic breathing stuff, and maybe I don't even care to learn that stuff, but I'd like to be able to design my programs in a manner that allows my clients to improve their movement capabilities while focusing on their fitness goals. I have an answer in terms of how you could meet all three of those things. And the answer is Human Matrix, my seminal seminar. I'm working on some major updates while I'm in my new somewhere. I definitely want you to come. The testing is going to be way simpler. The explanations are going to be way more better, and your people will be in business. Be ready to take your clientele to the next level. Here's where I am next year. Scotts Valley, California, January 25th and 26th. That one is almost sold out, folks. So if you are looking to come to Scotts Valley, you probably want to sign up ASAP. April 4th and 5th in Atlanta, Georgia, where the players play. That's coming up. May 23rd and 24th, we are in Dickinson College in Carlisle, Pennsylvania. June 6th and 7th, Minneapolis, Minnesota. August 1st and 2nd, Boston, Massachusetts. September 12th and 13th in Montreal, Canada. And October 3rd and 4th in Ann Arbor, Michigan. And a new one, folks. Charlotte, North Carolina, November 7th and 8th. Just signed up this past week. Be there or be square. Those are where we're at today. I am highly likely going to have one more, but I don't want to reveal it yet because we're still sorting out the deets. So I hope to see you at one or more of them. I'm hoping to do some incredible updates, also to some of the pre- and post-course material. So stay tuned. The last question, I'm pretty jazzed up about this question, comes from my dude, Alex, the legend. Here's the question. Where does bruxism during sleep factor into the nasal passage airway picture in terms of potential causes, and what would some of the solutions be? I have an off-center bite, which has caused teeth to wear down, and bruxism has become an increasing issue. My dentist gave me a night guard, But after the gradual onset of severe headaches, jaw pain, face pain, neck pain, and thoracic spine pain, I stopped using it. Smart man. I need to get this addressed, and I need to be better informed to make sure I go down the right path. Thanks. Alex, I'm super excited that you asked this question. What is bruxism? Bruxism, and I'm basing this off some of the research that I've read on bruxism, which I will link the two. There's two really good articles. I'll link them both in the show notes. Well, one I'm a little pissed about because it like went through and I'm like, oh yeah, they're going to check this research stuff and all that, and then it just went to the discussion. I'm like, what the hell? And I looked up at the title and it was a protocol. It's like, just do the study, but neither here nor there. Definition of bruxism is teeth grinding, gnashing, and clenching during sleep, that's sleep bruxism, or while you are awake. In terms of sexual differences, females are more likely to present with awake bruxism. There is no difference between male and female when we're talking about sleep bruxism. Occurs in 8 to 31% of adults. There are some certain risk factors you can have that may make you more predisposed to being a bruxer. Smoking, no bueno. Certain medications, chronic L-DOPA use, hashtag Parkinson's disease. Also long-term SSRI use, so your antidepressant medication, that could potentially be a contributing factor to bruxism. And my specialty, breathing problems. There are some links that this may be linked to some sleep disorders. In fact, they're calling bruxism a sleep disorder. And last but not least, a highly stressful life, though that is more for awake bruxism than it is sleep bruxism. Interesting statistics. 80% of bruxism episodes were associated with an arousal response and involuntary leg movements during sleep. So point being is bruxism and sleep disorders are very much intertwined. Thus, we have to look at why might someone become aroused from sleep. And a lot of this was really clarified to me in the myofunctional course that I took. They hypothesized that bruxism was potentially an attempt to open the airway to breathe. So consider this. If I have a low resting tongue posture, meaning my tongue is not on the roof of my mouth, it falls flat as I sleep. When you have a low resting tongue posture, the tongue is pushed more posteriorly. That creates a reduction in the airway by collapsing the pharyngeal wall. Thus, in order to open up the airway, you may brux or grind your teeth in an attempt to move the mandible forward. And if you are unsuccessful, that might actually wake you up because you're having an apneic event. That was the thought process as to why this could potentially be one reason you could brux. There's also some stuff that's a little bit more literature supported showing there's been changes in the autonomic and central nervous system as well. But if we look at the treatments currently that have been shown to be effective and ineffective, it might point us toward a little bit closer towards this airway thing that we're talking about. So treatments that are effective, and I'm going to create a table for this and I'm going to put it in the show notes for you. But let's look at ineffective treatments first. Splinting, so putting a mouth guard in or an NTI, a nociceptive trigeminal inhibitor. Things that would prevent you from grinding your teeth in theory have not been shown to change bruxism whatsoever. They are there simply to manage symptoms. Sleep hygiene efforts, changing that, has not been shown to be effective, which is kind of interesting. Chronic L-DOPA use, we talked about that. This one I thought was super interesting. Occlusal interventions, including attempting to change occlusion with splints and also doing other treatments to try to develop centric relation or getting the occlusal contact of the teeth effectively, not been shown to be effective. In fact, when they utilize occlusal-based splints, 50% helped in this one study that they talk about, and in the other 50%, there was either no change in bruxism symptoms or the symptoms were made worse. So point being, it seems to have been pretty much disproven that occlusion and bruxism are linked. which is interesting, Alex, because you point out that you have an off-center bite, but that, even though you have that, that might not be the reason as to why you have bruxism. Things that are in the middle. There's not enough research to support efficacy for improving bruxism. Contingent e-stim, so electrical stimulation to change the contractile orientations of the muscles that are involved in mastication. Botox also might be something to consider. Things that are effective for bruxism. Relaxation and biofeedback, but not effective for sleep bruxism, effective for awake bruxism. So you just cultivate awareness of when you are clenching your teeth when you're awake. I think that's pretty useful. This medicine called clonidine. This was kind of interesting. Clonidine was shown to reduce bruxism, but that has some negative side effects. 20% of the people who take clonidine have been shown to have severe hypotension, so low blood pressure, upon awakening. Not a good thing. This is where I think the breathing piece comes in. Mandibular advancement appliances have been shown to be effective at improving bruxism. If we think about what I said before, low tongue posture collapses the airway, you need to do something to open up the airway so you get air. An appliance that pushes the mandible forward might be able to increase the airway dynamics or open up the airway and reduce the need for bruxism. So appliances that go on the mandible could be useful. But an interesting tidbit about that. They did, when they were talking about this study, when they utilized these appliances, regardless of the extent of mandibular protrusion that was utilized, there still were significant improvements in bruxism symptoms. So even if you didn't create protrusion of the mandible at all, you still got an improvement in bruxism symptoms. And they hypothesized that because there's local discomfort when you're wearing this type of appliance, that the pain actually offsets the bruxism, in the sense that if you're feeling pain, you're not going to be clenching or grinding your teeth. So that's kind of interesting. So still a little bit of uncertainty in terms of why that appliance works. Using a little bit of L-DOPA acutely or in low doses, which is traditionally a Parkinson's medication, also shown to have some positive impact. And this one is interesting. Tonsillectomy and adenoid removal. If you remove those things, that could potentially increase the amount of room in the airway, allowing you to breathe more effectively. So we potentially have two treatments that are more airway-centric in the mandibular advancement appliance and removing the tonsils and adenoids that could potentially positively impact bruxism. And what we do see is there's not really much link to bruxism and occlusal factors. So to me, and let me preface this, I don't treat many people for bruxism, but if I were to, I would definitely consider going the airway route. Obviously, that's a little bit of my bias kicking in as well. So things to consider would be improving the upper airway. How do we do this? Well, obviously, there's two potential ways you can do that. That's literature supported in the mandibular appliance, as well as getting the tonsils and adenoids removed. Obviously, if you need that, you need to get evaluated by a practitioner such as an ENT. But I would do all that you can to improve upper airway. In terms of conservative measures, myofunctional therapy is a great way to increase the dimensions of both the mouth as well as the upper airway. There's lots of exercises you can utilize in that regard. I am certified in myofunctional therapy, and I've worked with a few people here and there in terms of improving upper airway dynamics. So you might go ahead and search out a myofunctional therapist or come with your boy, and you'll get a comprehensive approach with that. That would be one thing I would definitely consider. The other thing I would consider is make sure you get evaluated by someone who appreciates upper airway, and that's probably an ENT dentist referral, depending on what your symptoms are. If you need to get the tonsils and adenoids removed, way to see that would be opening your mouth and how much of the back of your airway can you see, or can you see your tonsils and adenoids collapsing it? That would let you know that you need that to be taken care of. That's an ENT fix. They can also look up your nose to see if you can get adequate air through your nose, because one reason you could have a low resting tongue posture is because of some inability to get air through your nose because of some structural issues. So that would be one thing to look at. If you have any allergies, that would be another thing to consider. There's also some structural things that can happen within the mouth, and that's where a dental referral can come into play. And that might involve utilizing appliances or potentially referring to an oral surgeon to increase the amount of space in the upper airway. That can be done with dentistry. Regardless of the more aggressive approaches that you go down, it would behoove you to incorporate myofunctional therapy, and I would argue airway therapy from the neck down along with that. There is some individuals who can get some of these procedures and have a relapse. And the thought process is because even if you change the structure, if you're not changing the neuromuscular activity or the dynamic capabilities within that region, you can have a relapse and stuff. And I have some colleagues who've had some people who've had the surgery where the maxilla and the mandible are advanced forward, and even though they had that surgery, there was a relapse in terms of the efficacy of it. That was fortunately fixed with myofunctional therapy. So that would be something to consider. If you're going to go this route, I would definitely get evaluated by a dentist, an ENT, but also make sure you are doing some type of myofunctional therapy along with this. So to summarize your awesome question, Alex, bruxism, grinding of the teeth can happen while you're asleep or while you're awake. Probably associated with arousal and sleep. In fact, it is associated with sleep arousal, and that could be contributed to some airway issues or an inability to get enough oxygen while you're sleeping. Fixes, things that are useful. If we're talking about more conservative measures, myofunctional therapy, I think, is definitely something you need to consider regardless of what you do. But mandibular advancement appliances, tonsil and adenoid removal, and I would also say getting evaluated by an ENT and dentist to potentially change some of the structure in your facial region would be incredibly useful. Splints and occlusal things are not useful. They are to be avoided, as would be making sure you are checking your medications to see if any of these could be causing bruxism. But if you focus on those things, and focus on your breathing, focus on your ability to get air and while you're asleep and you're awake, I think that could have an incredibly favorable impact on bruxism. And I think that's a good stopping point for us today or tonight. I want to thank all of you beautiful, sexy, outstanding people for tuning in. I will get back on a regular schedule next week. I apologize for the prior weeks. I was sick, and then holidays, man, they screw up with stuff. But if you want to learn more, go to zachcouples.com. There, I'd like you to subscribe to my newsletter. Here's all the good stuff you're going to get by subscribing to my newsletter. You'll get 5 hours of lecture. The lecture will be respiratory focused and pain focused. You'll get a free acute to chronic workload calculator, which will help you safely and intelligently progress the amount of workload that you and your clients have. You'll get goodies every Friday, exclusive to you for the most part. These will be things I've found on the internet that I think are useful, that I think you might benefit from checking out. You will also get access to my free course, Human Matrix Foundations. It is part of the pre-course material to my seminar. If you want to learn basic respiratory mechanics, as well as some physiological stuff that can prep you to better consume the material that I teach, I would love to have you there and love for you to check that out. There's also some services I offer on zachcouples.com. Movement consultations. If you toy and you're not moving as well as you'd like to, or maybe you have bruxism. What's up, Harold? You have bruxism, and you're like, man, maybe if I address some of the myofunctional components as well as the lower airway stuff, that could help. Or perhaps you're a trainer or a clinician, you got a troubled client, and their movement capabilities are limited, and you're like scratching your head, man, I don't know what the next step is. Well, let me scratch that itch for you, because you can work with me in a one-on-one setting. What we'll do is we'll take you or your clients through some testing. We'll perform some interventions to improve movement capabilities and get you on your way back to living life the way you need to. If you want to take that a step further and take those movement limitations that you may have, but apply them to a fitness context so you can improve your movement and your fitness goals, then that's where online training comes in. There, I'll take that information, put it into a training program that is specifically tailored to your fitness needs and help you reach your goals faster than ever before. Also, if you're a trainer and you're wondering how I program this stuff from a fitness perspective, that's a great way to go through and learn kind of the thought process behind what I do, and I can mentor you through that along the way. Which takes me to the next stop. If you want to learn how to do some of the stuff that we've talked about today with your people, maybe you're like, yeah, you know, Zach, this all sounds well and good, but I don't know how to apply it to my specific population. Well, that's where the mentorship program comes in. There, what we'll do is we will design and collaborate together on how we can best apply some of the concepts that I discuss to your practice. It'll be a lot of good back and forth dialogue. This isn't just me lecturing. I want you to be active in this role. You're going to have some post-mentoring homework to carry out that will allow you to better solidify your learning and guided application so you can get the most out of what we discuss. Once you've scoured ZachCouples.com, you'll want to check me out on iTunes and Stitcher. Because guess what, folks? There are 105 other debriefs. And, you know, your boy wasn't always looking so good in the earlier ones. It was a little gaunt, a little too thin. So maybe you want to go on iTunes and Stitcher and take me on a long car ride and listen to me. Check me out there. And while you're there, please, please leave a review so the fam can keep growing. I'm on social media, of course, as well. Facebook/ZCouples. The Twitter handle is @ZCouples. Of course, I'm on the Instagram, baby. Zach, Z-A-C, Couples, C-U-P-P-L-E-S. And last but not least, search me on YouTube. Just search Zach Couples. If you want a gang of exercises, they're going to be on the YouTube channel. The debriefs, the HD version, well, man, I'm going to get really sexy with this one. That's going to be on the YouTube channel. There's going to be a lot of good stuff there. Also, this will be on the website tomorrow or tonight. Thank you so much, you beautiful, sexy, outstanding people for tuning in. I hope that the rest of your weekend treats you well. Keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving. And I'll see you next time. Deuces.